So case presentation, actually, all of you have been doing it since your uh, MBBS days. You have been presenting cases right from third year onwards, which we used to call as the third year. So as soon as you started your clinical postings, you've been presenting cases, be it just history to begin with, then examination. So, but every on occasion where you present a case, there's a slight difference in your presenting style, the content, and that has to be kept in mind. So the purpose when you present a case could be that you're seeing a patient in the outpatient department, and you need to discuss it with your consultant, or you need to just discuss it with your colleague, or the patient has been admitted to the ward, he's a new patient, so you have to discuss that patient in detail, or you are just presenting a follow-up next day on the ward rounds, or it is a department meeting in the academic morning class you are presenting, or you're presenting it to a large audience, say in a conference. It's a very interesting case you're discussing there, as in a meet the professor session, or whichever session is available to you, or you're discussing in a telemedicine or a telehealth consult or a conference. So the place where you're presenting a case, you have to modify the way you're presenting the content. The gist or the summary of the history and the examination will be the same, but the way you present, the details you provide will change with the type of audience you're presenting, and the discussion which will follow the case will also vary with the audience to whom you are presenting. Say in an outpatient, you will not go into the details of the case series or go into the details of pathophysiology, because you have other patients who have been waiting to be seen and the treatment to be prescribed. In a ward round, yes, if it is a free day for you and your consultant, you don't have an outpatient or an intervention planned, or an intervention clinic like endoscopy or dialysis clinic, or you don't have an OT, then definitely inpatient, you have in-depth discussions on various days. Someday you could discuss what are the differentials. Then the consultant may ask you to read about the treatment part, or the approach that we are missing out something, what else can be done, which is a better modality of investigation. So all that you could read up and then discuss threadbare and give a proper management, improve upon the management of the patient. In department meetings, generally you present a case as an academic presentation. You focus on one aspect of it, or if you want help from your other faculty members or colleagues in your department, then you present a particular aspect which which has to be uh, dealt with. Suppose there is one particular aspect, say for instance, this patient of Cushing's, we are unable to localize the lesion. We have done all kinds of investigations trying to see whether it is a pituitary dependent Cushing's or adrenal, but nothing is coming out. So you would like inputs from other faculty colleagues, and you would present and just discuss about that part, not go into the depth of how you diagnose Cushing's, and because the person whom you are discussing with and you yourself, both of you know that level has been reached already. In a larger audience, again, if it is a research-based case, you would talk more about the research aspect or a new aspect of what you want to present. So you really have to bear in mind the audience and the purpose of your presentation. So general points which you should keep in mind is that, as I said, that you need to be really very clear why you're making the presentation. You should be well prepared, because you don't know what kind of question on which aspect of the case would come up. Somebody would still be questioning your diagnosis, so you need to be very clear. Just stick to your case, don't wander around. And obviously in all presentations, as you heard from Dr. Paliwal, that you need to know what is your time, and you need to stick to that time. And especially in your department meetings and interactive case discussions, always allow enough time for interactions, interjections, and responses. And because every response or interjection may have a counter question or a comment from other people sitting there. And why are you presenting this case? This case you're presenting because it's an uncommon diagnosis. People don't see it. So you just want to enlighten or educate other members. It's an unusual presentation or a course of a common illness. Many times in Cushing's, when we investigate a patient, sometimes the tests which are done to confirm Cushing's are showing that the patient has Cushing's. We call the patient back for, say, MRI, other tests. And before we do the testing, again, we have done a test to confirm whether the patient still has active disease or not. And then you realize that the Cushing's test have come negative. So this is something called as cyclical Cushing's. So this is very uncommon presentation of a common condition of Cushing's syndrome. So maybe you want to present the case that way, or you want to emphasize on an aspect of management, or there's a clinical dilemma, so you want a discussion. I'm not going to go into the presentation. Generally, you should have 1 slide per minute. That is the rule generally followed. So what is the general scheme of presentation? It is introduction. You could just say that why you want to present a case. That just could be 1 line introducing your case. Then important is the case history, examination, the investigations, and the discussion and review of literature. That is the important those are the important components of your presentation. So when you start the actual case presentation, you start with the relevant history. And as is a general rule which is followed, you start history of present illness. But most of you, especially the DM and the MCH students, you would see that most of your cases are very complex. I would continue to give you examples of patients pertaining to endocrinology, because that's what I see here in the institute. Say a patient of type 2 diabetes. He has diabetes for 15 years. But today, when he has come to the outpatients and got admitted or whatever, his main complaint is that he has infection in his left foot. So that becomes his present illness. So in a general schema of presentation, you would start with the history of present illness. I would say that this patient, gentleman AK, 45-year-old, he has come with a history of fever for 10 days, pus discharge, swelling on the left foot, pain. But that doesn't give the consultant or your colleague or you yourself the patient as a whole. So in these kind of cases, once you've said that these are the history of present illness, and you just want to emphasize to the person who's listening to your history that this is an acute condition, which is whether the foot is infected or not, or he has just a neuropathic ulcer which is giving him pain. Once you have just told this brief history, you need to say that the background of this patient is. So you go back to the history of his diabetes he has for last 15 years, and then you go on oral hypoglycemic agents, and then you go full on to the whole history, which gives you the patient's present problem, puts the patient's present problem in a perspective, that this patient has uncontrolled or controlled diabetes. This looks like a vascular foot or a neuropathic foot. Everything, then you have put it in perspective. So, and other associated complications, does he have hypertension, nephropathy, retinopathy, because that will impact upon the management. So that is how I would actually present. There are some differences of opinion in how people would like to present, but this is generally, I find it an acceptable way by most people. And it actually, you've gone through the scheme the way it is, that you've presented the present illness in brief, and then the whole background history of the case, because it's a chronic condition. And then come to past history of other illnesses, and then come to the personal diet history, family history, and other aspects. We have, in pediatric cases, we have generally seen that we pediatricians have a tendency to go back to saying the birth history, the immunization history. So again, I would like to emphasize that all the past history or any other history which has actually no bearing with the patient or doesn't have any impact on the patient's health today or onto the disease with which he is presented, probably you don't have to present in so much of detail. To give you an example, suppose a child has come with short stature. In short stature, the antenatal history, the birth history, the early onset infancy, everything is important. So you would have to give all that history. What was the birth weight of the child? What was the developmental milestones, or how was the development of the child? All that part you do have to speak out. But suppose a child came with type 1 diabetes at the age of even 5 years. Other than just saying about his diet history, I don't think you really have to go into the antenatal, the perinatal, the postnatal history, developmental milestones, unless you think that this has some genetic component to it, or it is a syndrome on the background of which the patient has developed type 1 diabetes or diabetes today. So that kind of judgment you have to make, that whatever in the past history was there, whether it is relevant today and should it be spoken out in so much of details. When you're giving history, say for an exam, or when you're presenting in the outpatient even, if you want to be complete in your history, so when a patient of, say, diabetes comes, you want to tell you want to say that the patient doesn't have any microvascular complications in the form of nephropathy, retinopathy, neuropathy. You can just say that the patient doesn't have history suggestive of microvascular complications. So we would understand that you know what are the symptoms. But say for the same thing, you want to speak it out in your examination. The way to go about to speak in your examination would be, the patient doesn't give history of any microvascular complications like retinopathy in the form of no blurring of vision, no flashes of light, no sudden loss of vision. So you want to tell the examiner that you know what are the symptoms of retinopathy, you know the symptoms of retinopathy, nephropathy, neuropathy. You've covered everything. You get credit for it, that you've completed the history without the examiner having to ask any question. So same thing which you were speaking out in the outpatients, you are speaking it out during your examination or your inpatient rounds, but you don't go into the depths of the symptoms in an outpatient history, but you go into the depths of symptoms in your exam or your inpatient, making it very evident to the consultant who's listening to your history, or your senior resident who's listening to your history, or the examiner, that you know what all questions you have to ask to elicit history of these complications. So maintain sequence in which things have happened chronologically. Here, when you're speaking out the history or eliciting the history, after you've elicited the history, you really need to be very careful of the language, English language, prepositions for, since. Just a simple example. The same gentleman, AK, whom we heard a few minutes ago, he has come with a diabetic foot. So just understand how the meaning of the sentence changes. Mr. AK had fever for 5 days. He has fever since 5 days. So now when I'm speaking today on 2nd of December, if I say he had fever for 5 days, that means he had some time in the past 5 days, doesn't have fever now, right? And if I say Mr. AK has fever since 5 days, that means he still has fever, which is there for the last 5 days, and he continues to have fever. So this is how you really need to be careful of your language, because it gives a total, the meaning completely changes. And this is a very common example, which I hear day in and day out. So really, you really need to be careful. The other common thing which I hear in by residents, and even sometimes I have made this mistake and I've learned now not to do it, is that when a patient comes to the OPD or the ward, you say these investigations were done outside. Outside means right on the road, outside your ward, outside your OPD. I think a better way to say is that these patients were done in a private lab, or these patients were not available to us, which were not done in SGPGI. They could have been done anywhere in the world. Outside doesn't give you any indication. If you speak out that it was done in certain such and such lab, in endocrinology, the hormone assays are so dependent on the lab where they have been done that it's really important to know which kind of a lab it was done. So if you speak out that this is the lab it was done, immediately it registers to my mind that, okay, can I believe, or are the assay methods really good to take these results at face value, or I should go dig deeper and understand whether we can use these values or repeat the test. So these are very minor things which all of us should bear in mind, and probably be very clear in what we are speaking. Always make your presentations interesting with photographs, radiology, histopathology, not boring as I have done. I have not put a single photograph today for you. So please, and especially in radiology and histopathology, is very important. Put up an X-ray, CT, and just, even if you have a report, read that report pointing out to various lesions, what you're talking of. You're talking of adrenal, pancreas, the right adrenal limb has a lesion, just show it. So it makes it more interesting. Same with histopathology. You're showing this is a reticular nucleus, laden cells, or whatever you want to speak out. The crypts are flattened, so you could just show, sometimes put up a normal histology just to show that how a normal villus and a crypt ratio looks like, and this is how a flattened crypt is looking like. All these things make it worthwhile, and especially for people even to understand. And it's a learning exercise for people who have not been exposed to all these words, and maybe are listening, say a first year resident who's hearing it for the first time. Always, after finishing your history examination, at least have it in your mind and written down that this is the differential diagnosis and your reasoning for that differential. Very important. And provide follow-up data using flowcharts or tables. This is really important when you're discussing a mortality meeting or a patient who has a very long follow-up. And a final diagnosis with clinical outcome. Then when you're having a review of literature, just keep it concise. Maybe just give a brief outline that this is what you want to discuss. If it is a whole case, you could talk about, if you're discussing pathophysiology, just speak out that I'm going to talk about the genetic cause of this disease, say Coleman. What are the kinds of genes? I found this Coleman gene mutation. Is it known? Is it not known? How did I go about finding a novel mutation? Those kind of things, and try to pull out literature supporting your finding. And the articles which you should use with the PubMed and with the internet available, a common thing seen mostly in our morning class presentations is that whatever is freely available on the net, generally those articles are used. Over the period of time, try to imbibe and learn that which journals get good articles or articles of really clinical importance. Every field would have certain journals which really have the path-breaking kind of treatment or studies, or which are really key in the pathogenesis or any aspect of that particular disease. So please try to, even if it is an older literature, at least that was something which gave a direction to treatment in this aspect. Say, for example, we have something called as hypogonadotropic hypogonadism. it is a congenital, you can have a congenital hypogonadotropic hypogonadism. But way back in 2009 in NEJM, an article had come which showed that in spite of it being a congenital, there are some patients who actually spontaneously recover. So whenever somebody presents anything on hypogonadotropic hypogonadism, that article, when they're talking about management and follow-up, that article at least should be mentioned, because that was the article which told us that you really have to follow up these patients for a longer period of time. You can't just say that this treatment is permanent. They will require testosterone replacement or E+B replacement all their lives. There is a chance of recovery. So it is 11 years old now, but still it's an important article. So those kind of things have to be remembered and presented. And definitely when we are presenting, we should try to look up for studies available from India, and literature should be specific to one point which you're discussing. Please don't make it into a seminar for that disease. Just stick to the review of literature for one particular aspect which you're presenting for the case. And avoid using solely review articles, because you're trying to look for a specific aspect. There could be just case reports for it, just or a case series of 4 or 5 cases. But it may be important because it has similar features or similar management issues which you are discussing. In interactive sessions, as I said, leave enough time, stop and maybe ask questions, or maybe give time for people to interject and ask questions. So these are the common errors, as I said to you earlier, that unless you plan and have good quality slides, any presentation will be fraught with danger. So a couple of slides just about mortality meeting. The presentation of the case usually similar to how you would do a case presentation. Here, the sequence of events have to be clearly presented. Investigations and clinical course as a graph is always better, with arrows pointing towards your change in treatment or your thought process. If you have it on a graph, you could put an arrow and say, this happened here, the clinical features, what happened, what were the investigations at this time point, and this was your thought process, and this action was taken. So it pictorially depicts the whole course of events for that patient, from the time the patient was admitted till the unfortunate event which happened. And what was the terminal event, what happened, all that has to be clearly presented. And the aim of mortality meeting, which we normally have as a CGR or audits when you have in your department, the aims are basically to elicit that during this case management, what was the problem you faced or encountered? Was it the presentation has to come out with that? Was it a diagnostic difficulty? Was the availability of treatment not there because of any cause or any problem? Was there a complication of treatment, or there was a misjudgment or an error of judgment on our part? All that has to be brought out clearly and has to be explained. And eventually the final aim of the whole exercise is to have some learning points, that if you were faced with the same problem again, how would you do it differently? Or what have you learned to make the outcome not what had happened at that time? And does this learning exercise involve a change in your diagnostic protocol, your approach to the patient, or the treatment which you would have provided? So that means, does it involve that you have to change the management of a similar case? So that is the important aspect which has to be brought out from a mortality meeting presentation. So this was what I had to speak about case presentation and mortality meeting.